on yet. Okay. Well, maybe we'll go down to agenda item 5 as is at the moment. In the minutes of the previous meeting, I'll be happy to accept those minutes.
Yes.
Thank you very much. See whether still not here. Okay. If we can, there are no matters arising from the minutes. If we can pass over then to Joe, is it you speaking to agenda item?
Is there anything duplicate to say?
I don't know if there's anyone else joining us who wasn't in that.
I don't think there is.
Is it the same audience?
Yeah.
Do we have to put this on the public record though, this meeting?
Yeah.
Are we not recording it for the public? I don't know.
Yes, we are.
Yeah.
So
Is there any finance we need to mention? I'm not sure there are huge numbers. I think because it's the last meeting, I guess just to note some of the items that we have talked about in some of our previous meetings relating to the closure of all the functions and trying to make sure that we're keeping everything safe and managing all the transition. I think that's probably where most of the focus is at the moment. So yeah, I think we have apologies from Mark Adams, who's dealing with another issue that can't join us for this normal report. That's probably any other thing today.
okay. Joe, you have that as well?
Yeah, just so.
Yep.
Right.
Okay. Thanks very much. That concludes that agenda item. Now down to agenda item 8.
So we could just let Sam
In
in.
the absence of
Brilliant.
health colleague.
Judge remarks be unwritten in infections or anything, is that what we're going to do?
Come back to the end there.
We've got at the end, haven't we?
Yeah.
Agenda item 8 then, I think going down to, which is the CCG PPI update. Paul, is that over to you?
I think so. Yeah, Monday's not here, is she?
No.
Yeah. Great, right. I'll just pick out 1 or 2 highlights. So hopefully most people it was nice to see about long-term conditions being visited by the people from the QE and thinking how they can utilise it. They've done a lot of good work, that group, over the years, and need to be congratulated on what they've done. I think it was Steve Kirk who helped set that up originally. So it was a great piece of work. And I think that's a model for the future. We do need more kind of utilising things from each other's services, and hopefully more of that is going to be happening at place. I guess that's one of the encouragements of place. It's nice to see under the community mental health conservation that the peer support workers has been more treated now, so that's been very successful. Nice to see the teenage health resources gradually coming to a conclusion now, and looks very positive. It's a shame that that's not going to happen before we finish. As a CCG, it would be nice to see, but that's really good. I think there's a suspension because of things that happen, because of the changes now with the forum. But that's been a really good forum in Newcastle, working well. All the things from Send, very good. It's nice to see all that continuing. I think the work that's been done around the Newcastle practices to help develop the practice patient groups, that's really good and a nice positive development. And I know a lot of people who over the years have contributed to the different engagement forums. There's people coming interested to help engage with health services. I know a lot of them would be very pleased with that because that was a subject close to their hearts. It's nice to see the whole engagement strategy developing around the ICS. It sounds very positive, so hopefully it'll be good. I suppose just on the note to address to them that if what they can do is to make sure that there's always feedback to people, because I think it's still lacking. When people have been consulted or even engaged for their views. There should be feedback on what has happened with that. What's been kind of not been able to use or not been able to take forward and why, and what has been good and what has been taken forward. But I think that's one of the things that people still complain is very lacking. So that would be really good if the RCS and any other forum could take that. And hopefully will be taken up by that point under 4.2 about reimagining engagement support. There's a lot of people just see that cynically as they have done in a lot of our little reorganisations past and think it's just about saving money. But I think there is that important point about trying to make best use of all our different resources right across place and across the ICS. So we do it well and much better and include more and more people. I think we'll get a wider audience that way as well. So that'll be really good. I think they're just the main things that I want to pull out really. Just want to say thank you to the involvement team in the CCG. Like all parts of the CCG that work without, it would have been always nice to have more staff and more money. But they've done a really good job. So thank you to them. And thank you to all the people that turned up to all the different forums and contributed their opinions over the years. I think people are still suspicious. I keep trying to encourage people to, even if it's not make a complaint, make comments about improving services. And I think gradually people are realising that that does work and it makes a difference. But it's been a gradual thing. So big thank you to everybody who turns up at all the forums and shows an interest and have contributed over the years. I've certainly appreciated their involvement. So any questions, I guess?
Thanks very much, Paul. Any questions or comments at all? Yes.
I just wondered about how this kind of level of lay member involvement here with CCG will carry on under the place arrangement. Obviously, at the ground level, things is going on there, but we'll be coordinating, actually putting the whole thing together and making sure that actually there is a difference between the people in Newcastle against it.
Again, it will be different rather than the same, won't it? And I guess there are new opportunities with place-based working to work with our council colleagues and elected members as well, and trying to think how we bring that the sum of the parts together in a way that serves our public the best. I think at the moment we've got a really good set of relationships between our communications people and our involvement teams, and I suspect that will evolve, but I think it will be different.
I agree. I think that's certainly the plan for Newcastle, is to look at how we engage as a system with the various geographies, cohorts, population groups, as a collective. Because I think one of the things we've learned is that we can sometimes over-engage in the wrong ways, whereas we need to do it better. So I think we'll utilise the skills of the people that you've just described there that will remain with the ICS, but they will work with the system partners to take forward.
Actually, you've got a joint appointment in terms of participation for children, but it's a start. So that must help to bring together those two things. Be interested to see how that course gets on. I think it'll do really well.
I did miss one comment out actually. I thought it was a very positive development on the ICS to be thinking about this kind of citizens panel.
Yeah.
And I think that might be a good way forward. And it may be that maybe that's a good thing to develop in place. But again, it depends on how it's serviced and powered and used. And not used, but worked with really. Because sometimes in those things, I think people feel used to be given presentation after presentation. Whereas I think they want to be engaged more than presented to. So it's about more that co-thing really. And I think that'd be great. And I think that citizens' panels are quite positive development.
Okay, I've got Shanaz and Jeff. I think Jackie wants us to come back on that point. Did you check it?
I was just going to say that one of the appointments at the ICS level is Annie Laverty, who is one of the region's champions for engagement and has sort of had that as her background for a significant period of time. So I would expect her to drive it.
Excellent. Okay, thanks, Jackie. Can I bring in Shanaz and then Jeff? Shanaz.
Just that in the PCN enhanced service, there are specific requirements now for us to address around core design and engagement. So there is a specific enhanced service for health inequalities, and we have to identify specific groups that we're going to work with and connect in with them around that core design. There's a whole schedule in there about how we connect in with communities and involve them in the corporate work and PCN boards. So we're doing all the stuff around food and holiday hunger. Out of West PCN are doing some stuff around digital inequalities, and the PCN in Gateshead is doing stuff around learning disabilities. So we've already started to do all of that work, which I would imagine will feed into our place-based fora because we're doing this on a day-to-day basis now.
So, thank you. Can I just quickly bring in Jeff? Jeff, please.
Yeah, thanks, David. Paul, you issue a good challenge to everybody about how to maintain all the good work, and I think one of the benefits might be that as the majority of our services take place across place boundaries, is the opportunity for some joined up consultation, actually, rather than the individual CCG trying to consult on a service that covers a large geography. We've actually got the opportunity for somebody at the ICS or the ICB to take that consultation to the wider geography and really tie it in and get a better view, given that the geography of some of those services is rural, coastal, and urban, and everyone has different needs. So I think there's an opportunity to do more and do it better as well.
Great, thanks very much, Jeff. And Paul, did you want to come back in?
Yeah, I think the other thing, just reflecting back, I think what would be good is if we did have a space in terms of consultation, feeding back people's views from staff, that there was a space there from staff to be feeding back views that they get from people. Because often they do pick up a lot of the ideas and opinions and people's comments about services and things. And there is a chance to do that. And there's actually a chance to do it actually a structured way as well. It might be one day every 3 or 4 or 6 months or a year, where everybody just asks whoever they're working with, about the little thing that they might like changing or like seeing improving or whatever. Because that's it, just start people constantly coming into contact with people who've been given views and ideas. And it'd be nice to find a constructive way to feed some of that back as well.
Thanks very much. I guess going forward, I think what I'm hearing is that we all appreciate the importance of hearing the patient voice and getting their input into the design and development and performance of services. And it sounds like there are some innovative ideas going on, thinking about how that's done at a system level across different geographies. And I'm sure some of your ideas like that, Paul, will be the sort of thing that hopefully will be taken forwards, recognising there are different ways. And I think the paper you presented today recognises the different ways that we can hear and understand the patient voice in the design and development of the services we commission. So, yeah, I think it sounds positive going forwards. I just wanted to take the point that, just as you've said, Paul, I think to thank all those involved in our PPI teams for all the work they've done over the years, and to you and Mandy for the work that you've done and for bringing the papers here and presenting them so well, and all the great work that's gone on in that particular area. So thank you very much for that.
Yeah.
We're on to, I keep imagining we're going to be jumping into public health, but they're still not with us. So, yeah, so we'll get on then, I think, to agenda item 9. Please, is that you, Joe, on quality, finance and performance?
Yes, in tradition, should we take the quality section first?
Mm-hmm.
Yeah, thank you, John. So I'll turn to page 2 first, which is the executive summary, and I'll assume that people have read the report. I don't intend to pull through it in any detail, but happy to take any questions. So the key risks are flagged on page 2, the ongoing issues of infection prevention and control as a response to the pandemic, and as we know, the rules have changed even just in the last week. We've had further updates on social distancing, mask wearing, and additional challenges with the additional infection outbreaks that we're dealing with. So that's on an ongoing basis. We need to be flexible, fleet of foot, and make sure that we respond to all the latest requirements that we need to meet.
The capacity refers to general service delivery capacity, and that's across all areas that we need to deliver our services for: primary care, secondary care, mental health, community. Everybody's really struggling with the capacity that's needed as we emerge from the pandemic. You know, the hidden harm that people have suffered while they've been waiting and then now presenting. So I know primary care, a lot of patients can't manage within the 10-minute slot. They come with a list of things that need to be addressed. The backlog that we're working through, you'll see in the performance data, where we're trying to achieve the long wait targets and make sure that we're maximising the elective capacity we have available. And then workforce is an ongoing challenge. And I think, you know, we've seen in the press that there isn't a significant number of unemployed staff, but actually what that means is that we need to make sure that from a health and social care perspective, we're an attractive option to come and work with us. Bed availability in theatre sessions, again, that's particularly with regard to the elective recovery programme. We've noted that despite all of those challenges, the CQC ratings remain good and outstanding for our organisations across the patch. And then we've just noted some key achievements at the bottom of page 2 in terms of response times, waiting times, etc. The areas where we're not meeting currently, again, it's the details in the performance report, but I'll just draw your attention particularly to A&E waiting times and referral to treatment times. And the urgent care demand has been a particular challenge over the last few months, particularly with the bank holidays. And we're doing more assurance work as we're heading to the Jubilee long weekend that's coming up to make sure that we've maximised everything that we can. So we've got significant communication exercises, and people have probably seen already messages to make sure you've got your repeat prescription in good time, etc. So every opportunity we can take to make sure that we can minimise that demand on our services. I'll move on now to page 6. In terms of the summary, the quality dashboards, obviously a lot of the mechanisms that we routinely have to monitor the quality performance were stood down during the pandemic, and in particular the MRSA and HCAIs, we didn't have the same robust approach to that. And as you know, our QRGs have been more of a light touch and by exception rather than how we would have previously done it before COVID. If I just move down to page, sorry, just missed the page number there, page 7. We have had an ongoing problem with the, you'll see the red boxes with relation to Gateshead hospitals and their incident reporting. Jill Finley's in post as the Executive Director of Nursing, and they've reviewed a lot of historic reports. So I'm delighted to report that they are now coming through in a more timely fashion. Jill's done a targeted piece of work with that, and you'll see those percentages improving dramatically over the next few weeks and months. So that's really good news on that one. And then you'll see at the bottom the staffing challenges are across the board, which I've already alluded to. I don't intend to cover that. If I just move down to the report on page 10 in terms of the significant events, and you'll see that Newcastle hospitals have reported 2 never events. One was a retained swab, and that came about a little short time after the surgery and was corrected, and the other one was a nerve block. So again, the investigations and the improvements in processes are being addressed with that. Sickness absence rates is another area for consideration, and I think that reflects the impact of the pandemic, outbreak management where we'll have to isolate staff for a particular reason, and then the ongoing mental health, stress and anxiety pressures that's being reported across the board. So we're trying to make sure that we've got every mechanism in place to support our staff and maintain health and well-being wherever we can. Picking up Paul's earlier points, we do capture some of the soft intelligence. So you'll see on there we do note our complaints, concerns, but we also note some good practice as well. We'll capture that through SIM, so I'll share that with Paul out with the meeting. Patient safety alerts are just noted on that page there, and then primary care quality. We've done some significant work on practices. Obviously, Dominic and colleagues have led on that with working on those that are flagged as reds, so that work's ongoing. And we're down the performance dashboards. I'll hand it on.
Thanks. Thanks, Julia. Just on performance and finance. clearly in the performance section report, there are a number of areas, in fact, many areas are flagged red, reflecting just how much the service is currently under pressure, but also how challenging the service is in trying to sort of restore to activity levels that we've seen pre-COVID. Julie's already talked about the A&E performance, and we're currently bubbling around the early 80% wise in terms of performance, both at Gateshead and at Newcastle Hospital. Slightly better at Newcastle Hospitals at sort of higher levels of 80%. I mean, I do have to say it is very variable, and I've just looked on across the whole of the region. All but one hospital is reporting both level 3, which is an escalated level of activity. So again, service pressures right across the board and right across all hospitals. In terms of referral to treatment time, you can see within the report on pages 17 and 18 respectively for Gateshead and Newcastle hospitals. Wait lists are still growing, 11,000 waiters at Gateshead hospitals, 99,000 waiters at Newcastle hospitals, and again you can see the weighted age profile on pages 17 and 18 of the report. We are seeing reduction in terms of the longest waits, in terms of over 104-week waits. In terms of Newcastle, we're currently in a position of 88, although that is reducing. By the end of June, we're on a trajectory of 63 of the longest waiters, i.e. over 104 weeks. And by the end of the financial year, March 2023, we expect the longest wait to number 30 at Newcastle hospitals. Just in terms of ophthalmology, I'm pleased to report to the governing body that there now no longer are any long waits in terms of ophthalmology, and the CAV cataract site continues to support the waitlist initiatives, particularly in terms of cataracts. Just looking at other areas of performance, in terms of diagnostics, we are seeing again service pressures. We are falling short of the percentage target of 99% in terms of echo and audiology, and current levels of performance are around 80%. I am pleased to report in terms of IAPT, we have had constructive mobilisation meetings with the new service provider. New service coming on stream in August. The contract value over the 5 years is 24 million, and we are continuing our waitlist initiative with an alternative provider in terms of just supporting them getting through the backlog in terms of the targeted therapies. In fact, we've awarded a contract with Insight for 750 patients, although we are seeing a number of patients want to revert back to their previous provider, Newcastle Total Therapies, in terms of service provision. Just in terms of the money then, I mean, quickly we ran through the annual accounts, so I don't propose to dwell on the money for any length of period, but if I can come back to your question, Paul, about the mental health capacity funding. The agreement did come to an end, but we didn't remove the funding, we just moved it to another part of, instead of being a section 75 pool budget, it was moved to a section 256, which just means there's less constraints around how the funding could be used and how we account for it. So we haven't, and just assuring the governing body, remove that funding, and the service remains in place. And again, just for the record, for this part of the agenda, in terms of the outturn position for last year, we did spend 1.207 million against a target of 1.21 million, and again that enabled us to achieve our control total set by NHS England. So we're pleased to report that to the governing body, and that's been our audited position.
Thanks very much, Joe. Thank you, Julia. Can I bring in Bill, please?
Yeah, I thought I'd, for this being the final meeting of the governing body, I thought I'd get in before the lay members get in, because they invariably pick us up on some aspect of performance, quite rightly so. You'll see that the cancer performance is not in a position where we would like it to be, and Claire Devell and myself have put Nuth under a fair amount of pressure to come up with recovery plans. They've provided them, we've discussed with them, and at 4:15 this afternoon we've got a meeting with Northern Cancer Alliance to discuss those plans in some detail, and whether they pass muster, I can report back at some stage in the future. But yes, we have been alert to this, and although we've given a little bit of leeway because of COVID, the point that's already been made is that by Julia is that many patients are now presenting excuse me, at a later stage than they otherwise would have done, and need the services to be as speedy and effective as possible.
Okay, thank you, Bill, for those points. Joe, please.
Thanks, Bill, for touching on it. And also just to add, Bill, when we talked previously about the pressures in the emergency workload, and actually that sometimes has an impact, in fact quite often has an impact on the elective work. But clear that the cancer patients remain as a priority, and avoid cancellations of planned operations for particular P1, patients.
Okay, thank you, Joe. Yes, Dominic.
So I'd just like to bring people's attention to 2 points. One on quality. So you'll see that we've written that we're achieving the referral to first appointment for IAPS targets, but I just wanted to, in the spirit of transparency, share what I think we all know, that that first assessment appointment to treatment beginning in the Newcastle part of the service has been unacceptably long, and that was one of the motivations for re-tendering or re-procuring that contract. So we're hoping that that will change, but that's not evident in this data, so I just want people to understand that. But secondly, in the performance data, a new sort of section that we didn't used to report on is the annual health checks for people with learning disability. We've gone from having a fairly static achievement of around 49%, which was below the 75% target, to exceeding the target for the second year in a row. We've achieved 82% in the CCG overall, putting us at the highest achieving CCG in the North Patch. And I think that represents proactive care for some of our most vulnerable patients. So I just want to point that achievement out from this paper as well.
Thank you very much, Dominic. Yes, Margaret.
Could I just mention 2 things? The number of over 1 year waits at Newcastle hospitals. It looks to be about 1,500 maybe. Do we have any projected timescale to achieve no over 1 year waits? I mean, it feels like it's going to be several years, doesn't it? 2 anyway.
Bill's got his hand up, but just to come back to your question, we are, as part of the revised planning, going to look at over 1 year long waiters. We're focusing over the 2 year long waiters, and particularly some of the real problematic specialties in spinal, and there've been long-standing issues. But we will move down from looking at the 104-week waiters down to we're getting more hard targets around the over 52-week waiters. So that will be part of the revised plan that we expect to see by the end of June.
Did you want to come in on that point before I get Bill in? Yes, sorry, just let Julie go first.
Well, Margaret, just to give you assurance, as Joel says, that planned move to step to each cohort as we move through. There's a twin track, obviously, to make sure that the clinical needs being identified and prioritised as well. And I think that just to make sure that we're really, emphasise everybody's committed to reducing this. So we're looking at the independent sector capacity, the FTs are swapping between themselves to maximise, because you need the data and the staff that understand the specialties. So it's quite a job to match all of that up to get everybody through. But honestly, everybody's working the best they can to maximise that and get those wait lists addressed, as Joe says.
Thank you, Julia. Bill, please.
Yeah, I'll come to Margaret's point in a second, but one thing I should have mentioned is that the gynae oncology services in Middlesbrough imploded earlier in this year, and their workload was taken up by predominantly Gateshead, but also Newcastle as well, with the result that no gynae oncology patient has had to have delay in their treatment, which I think is a pretty astonishing testament in the midst of a COVID pandemic. And on that front, in order to answer Margaret, Newcastle has quite a big waiting list for its spinal surgery. But again, there are certain aspects of spinal surgery that are only done in Newcastle and are not done in Middlesbrough. The thing that has happened is that Colin Smith and myself have been involved with Newcastle hospitals on the ophthalmology and dermatology pathways. I've been involved in the spinal task and finish group, and everybody has worked really hard to try and get this waiting list somewhere near a reasonable and manageable level. But the problem remains that there are insufficient clinicians, be they nursing in theatre, support staff in the laboratories, or medics on the front line, to complete the numbers in an effective timescale. And added to which there have been retirements and people have moved on. It's a really, really tough field out there, and people are retiring earlier than has been anticipated.
Thank you, Bill, for giving us some of the detail on that situation. Yes, Margaret, please.
Another point on page 22, children waiting for a wheelchair. Our performance is red, whereas our neighbouring CCGs are green.
Jackie, did you want to comment on that one?
Comment on the wheelchair one, yeah, we discussed this at the Senate forum with the parent and carers the other day, and actually the intelligence we've got from the service is that one of the things that are having implications for the waiting list is that a lot of them do not attend. A significant number of do not attend, which is actually having implications for those that are waiting.
Because the slot is wasted.
And they're quite a big slot, obviously, as well. So we are working on that actually with the parent care forum and the service to try and address.
Thanks, Jackie. Paul, did you want to comment?
Yeah, just to kind of reinforce Dominic's point, it's really good seeing that during the learning displays about the health checks. And I know a lot of work's also gone in on the people with serious mental illness as well to try and make that as well. So that's really good. Would it be useful to tell people who's got the IAP contract? Is it?
Yeah, it's public. It's called Vita Health Solutions. So it's a company that has delivered IAP contracts significantly up and down the country, and the evaluation procurement panel were very confident in their answering of the questions and in their ability to offer the contract. We're in a mobilisation period now where we're sort of discussing with them the GP and staff. I think it's probably fair to say that there was some disappointment that it was a company that wasn't viewed as a traditional NHS provider, but nevertheless they have worked at delivering this NHS contract very successfully in other areas in the country. So we're going forward with quite a lot of optimism that they're going to be able to deliver a service to people in Newcastle that they have arguably not had. You know, the waits at the worst were over a year and a half for basic CBT, which is clearly not what we want to offer to our public.
I'd just like to say it's great. I mean, sometimes the worst of times bring out the best in people and organisations, and it has been nice to see the way hospitals are helping each other and being more flexible about, giving services to each other and backing each other up for services. There's so many nice examples being around, and it's been certainly great to see them through the Quality Risk Committee and things. So it's just like a compliment to provide organisations and on people like Bill and that have managed to help stimulate some of that as well at times.
Yeah, absolutely noted. And I'm sure going forwards, I think the ask of the providers will be to work better, closer together with each other providers, but also with other colleagues in the system. And hopefully into the new world, we do see more of that positive working relationships. I was just going to make one point. We hear a lot about COVID recovery and elective recovery. We've obviously got a lot of numbers that are challenging for us. Do we have a sense, though, that we are in a stage of recovery? Do we feel that things are generally going in the right direction?
Probably a mixed picture. You know, when you look across the service, you can see some real pressure areas, particularly sort of urgent and emergency care. But as we articulate, you know, there are areas where, you know, we are seeing green shoots. I mean, the staff getting back at work, you know, is a real sort of boost in the arm in that respect. And, you know, we are seeing it start to come through in some of the elective work that we are seeing. But urgent emergency still creates so much pressure in the system. You know, we need to get on top of that.
Yeah, there are plans in place from the providers to move things in that direction.
I think just adding into that, David, I think we've got changes in the way that public access services, and I don't think that's necessarily going to recover in the same way. So whether it's a lower threshold to go to A&E, or perhaps for some people who are using e-consults, a lower threshold to go to primary care. There's different ways that primary and public are accessing at the moment. There are many public that still haven't accessed about services where their conditions haven't been met over the COVID period. So we know we've got late presentations. We know we've got workforce gaps, partly because they're still having to follow different infection control measures. We know that there are long-standing waiting lists that we've worsened. So I do think there's a real set of different challenges. So I don't think it's quite as simple as recovering from COVID. I know there are some structural changes that are with us for a while, and there are some capacity gaps. And we were talking in our meetings this morning about the plans for our diagnostic community hubs for trying to increase capacity where there are known gaps in capacity. And there'll be lots of other ways that we have to keep reforming the service to match the needs that we have. I think those needs are not the same as they were pre-COVID now. So I think it's transformation as well as recovery.
Okay. Paul, please.
So just if we have time, would it be useful to have a brief COVID update?
We can do it if we're able to provide that. I don't have any key headlines that we wish to share.
In terms of day there.
Yeah, just where things are at in terms of the systems and how it's looking.
The data's rubbish because we're not testing, so that will say that we're at about 100,000 again. So it looks very good, but we're still seeing deaths. So last week we had 3 hospital deaths. The week before we had 8 hospital deaths. So that for me is the significant factor. Care homes have only got 1 outbreak at this moment in time. GP practices have got none at all, L3 at this moment in time. So it does feel like it's a little bit easier in terms of vaccination. We're just getting absolutely pitiful quantities coming through for the vaccinations. So I think for next week it's about 400 for all of the GZ sites. It might be 490, but it's really good. So now, Sally.
I was just thinking, it's feeling as though patient flows are really, really smoothing, and certainly in the practices it's feeling, nationally I think things are really starting to calm down with regard to people being off sick with COVID, but the issue is that people are actually leaving and it's really difficult to reappoint into those posts. And the 2 areas, I think, we talk about GPs all the time, but there's a massive issue around nursing, but there's also quite a significant issue emerging now around non-clinical staff with the right skills. So it's the after effect of people, retiring early, deciding to leave the NHS for jobs elsewhere, that we're going to start feeling the impact of that. But one of the issues for me is, when we look at the numbers of people who are waiting for secondary care interventions, those people are going to have to be managed in primary care until they're actually seen. So we're going to see significant impact of that failure demand, where people are waiting to be seen in secondary care, but they keep bouncing back to us, but also issues around social care as well. So I know the questions about COVID, but I think the things that are happening in the system as a result are all impacting on general practice, because we can't shut our doors, as well as at the same time we're actually trying to recover in terms of the PCN contract and the GP contract. So it's really challenging out there.
We touched on that exact point this morning about the long wait as people's mobility is deteriorating and the pressure that's on general practice, while I wait for their operations. Yeah, we were just talking about that this morning.
I've got massive concerns about failure demand, and the other issue is actually we don't really have any. So we're going through and I keep talking about this, but we're going through a period of special cause variation. So we've been through the COVID period. We're coming out of it now, but actually the impact of that in terms of health inequalities, in terms of health and social care backlog, and all of those things, and then put on top of that all of the socio-economic impact that's affecting people. All of that is actually landing on our doorsteps.
There's a multiplying effect, isn't it? Absolutely.
Jackie, did you want to come in on
Yeah,
Newcastle?
very similar picture in Newcastle. Again, the numbers are okay, but it's still causing us pressure. We've had 5 deaths, the same as Gates had had, and we've got 6 care homes that are still in outbreak. Newcastle hospitals are reporting that there's still pressures on themselves. I think they've got 40 inpatients. They've still got staff sickness, which is having implications. Vaccine supply is really difficult, although it's there. It's available, but it's getting into the right place for the right people. Just listened to our interim director of public health talking about the inequalities, and we're still trying to address that and ensure that people who may be vaccine hesitant still have the offer available to them, even though it's quieter time in terms of communications. So it's still very much there.
Can I
And
just
of course, I was just going to put this in, of course, there's also the bit around the IPC. We're still masking, social distancing, and cleaning much more thoroughly, perhaps within the NHS than to pre-pandemic. So that also has an impact, in terms of the capacity of the system.
I'm not sure how this information is gathered or collected, but I was talking to one of our social prescriber link workers, and what she was saying is that the majority of people on her caseload at the moment are NHS staff who've had long COVID. And actually they're needing quite significant support, as well as around food poverty and things, because of the impact that's had on them when they come back to work. So we're supporting them and lots of other people with long COVID in primary care.
Okay, so it's going to have a very long current impact, but also a long impact, isn't it? The long shadow of the pandemic is going to be cast for some time yet, I would imagine. Okay, any other questions or queries or observations about the Body Finance Performance Report? Otherwise, we just here for noting for information. Thanks very much for bringing that today. Our public health colleagues have just...
But they have sent me a report for each place now. I will circulate that.
Okay, thanks then. If they do turn up, obviously we can bring them in to speak. If we can move down then to agenda item 11, this is the proposed constitution of the North Cumbria and North East Integrated Care Board. Over to you, Neil, please.
I'll introduce this. So it's a short cover sheet. I'll just pick up some of the points from that. And obviously there's the...
Sorry, Neil, could you speak up?
Sorry.
I think you've been let out the computer.
Move my computer away. So yeah, the Health and Social Care Act, as it is now, requires CCGs within our ICB boundary to propose the constitution, the NHS England. So although we're legally responsible for development, for proposing the constitution, the development work's been done by the ICB designated chair and chief executive with support from programme board and others. So we've had a copy of this report back in November. We weren't sure if we're going to get another version through in time to re-propose, I guess, but there's been a number of changes since November, and the timing worked out that we were able to bring an updated version to the governing body to approve and to recommend. So you'll see the attached constitution, there's some changes highlighted in blue which have been mandated from the centre, and the green is the local content that has been added by the ICB. The constitution itself is very similar in a way to the CCG constitution, as far as a lot of it is prescribed as part of the template. But you'll see there are kind of local additions that we can put in there. Not a huge amount's changed, to be honest, since the first time around, but you'll see that the sections that the constitution includes around how they make decisions, things like that, very similar to the CCG constitution, I guess reflective of the fact that CCG powers and duties are going to be transferred across to the ICB. A lot of the detail, I guess, on on the scheme of delegation, functions and decision markers not included in on the front or the face of the constitution, and those documents are being worked up at the moment to be agreed, and there are some draft versions but not yet ready for publication or circulation. But again, just I guess a peculiarity of the process, CCGs are required to consider this and then propose it to NHS-EI in the same similar way that we did in November. So that's the reason the paper's been brought today.
Okay, thank you very much, Neil. Any questions for Neil at all? So are we happy to, with being asked to consider, which we've done, and then propose it to NHS-EI?
Yeah, one of the requests is that can we grant delegate authority to Mark as accountable officer that if there are any changes post this meeting, that he can approve those on our behalf, and we'll obviously report those to the Government body. But we're not anticipating any significant changes after today.
Okay, are we happy to proceed on that basis?
Agreed.
Thank you. Thanks very much. Thank you, Neil, for that. Okay, agenda item 11.2. The report, the Workforce Resource and Organisation Development Report. Joe, please.
Thanks, Jen. So this is the Q4 annual HR and OD performance report for the CCG. In terms of workforce headcount movements, we are still seeing just a marginal increase in terms of the headcount. We are taking and hosting the designated appointments to the new ICB where they're coming from outside the region. Under section 3 of the report, in terms of equality and diversity, the graph showed the gender makeup, ethnicity and age profile of our workforce. And in terms of sickness absence, we are seeing a slight deterioration in terms of our sickness absence percentage rate. I mean, what is concerning for me is now that our position compared to our peer organisations, CCGs in the northeast and North Cumbria, we have the highest sickness absence rate. Although we are small organisations, nonetheless, I think our deteriorating position, and given where we are against our peers, is concerning. I'll talk a bit more about how we're trying to support staff in that regard in a minute. We can see within the charts the rolling average, the 12 months rolling average, and the snapshot absence rate, or the trend in terms of the two graphs that we see on page 6 and 15. And in terms of reasons for sickness absence, the classification S10, the anxiety, stress and depression is a proportion of the total number of lost days. We are actually seeing a slight decrease, although we are seeing an increase in reporting of unknown reasons. But in terms of, again, the known reasons for sickness absence, we are doing a lot of work through the health and wellbeing group in terms of supporting staff. And we have had Mark Sydney do a lot of mindfulness sessions with our staff, both as part of our whole staff sessions, but also individual sessions, and staff and dip in just according to whatever content there is in terms of those particular sessions. We constantly ask staff how we can help them in the workplace and help with cope with matters of sickness and absence, and how we can use the staff sessions to cover off issues of interest and well-being. And we can see under 6.1 the areas that and subject matters that we've actually covered or intend to cover over the remaining period of the CCG. So just to assure the governing body, staff and staff wellbeing does remain a focus of our work through the wellbeing group, but also through our staff sessions. I think I'll stop there, Chair, and just invite any questions.
Thanks, Joe. Any questions or comments at all?
Well, those numbers do change from quarter to quarter quite a lot, don't they?
Yeah.
And as I say, we've clearly gone in the wrong direction over that 1 year. But if we wind the clock back, we weren't in that bad a place at the beginning, were we? Is that, do you think, transitory? Because we are a small organisation, it only takes a few individuals, and
Yeah, I mean,
Though it
yeah.
looks like it's a trend
Yes.
going up, but is that perhaps just chance rather than?
It is. I mean, because we're such a small organisation, an individual with a particular issue who is on long-term sick, does potentially skew the figures more so than you'd see in an acute trust, or we are really exposed to that variability.
Yeah, sure.
Just
Yeah, Paul.
It's just been good to see the amount of activity that goes on in the staff newsletter, and kind of the offer of stuff. So
Yeah.
it looks really good.
Yeah, and I think the fact that the numbers, you just say, don't look as good as we'd like them to be doesn't diminish actually the huge amount of work and the diversity of work that goes on to try and support people. And I think, as has been said, it can only take for a small organisation a couple of people to be on the long-term sick and to have a big effect actually on the averages. Do you think, and we were confident about the support for staff through the transition into the ICB, that's had any impact on it? We feel that staff have been supported as well as they can be.
Yeah, and I think that's the point, that we're trying to support staff as well as we can and share whatever information we do have. Of course, we only know what we know, and as I say that, and to direct colleagues, I think these staff sessions are really, really good, really valuable. I mean, we had Suba talk about her wedding day, and it was such a colourful presentation. It was absolutely fabulous. So getting into equality and diversity issues is it's really good, really good.
Jackie,
I don't think I've ever worked in an organisation that has had so much support for staff, really. But go back to the staff sickness, so much of it has been unpredictable, very real, and they're long term. They have quite a number of long termers with very, very genuine reasons for being on.
Okay, but I guess that top reason that we have a sickness absence is probably most affected by transition as well, isn't it?
Yeah.
So there is a risk that with this transition, anxiety rates may go up.
We need to support staff as much as we can, and we need to hear from staff how we can support them too.
I should think that the next year for staff that is as important in terms of the transition. People may assume 1st of July you've landed. There's a journey to go on and support the ICS needs to put in place.
I'm not sure if it's the government or the NHS, but given the NHS is supposed to be a learning organisation, to kind of shove through the way the reorganisation's been going for this is plainly barking mad in many ways. It's crazy. And it's supposed to be a learning organisation, so I don't know if it's the government that's forcing it or the NHS, but it is creating the problems. So if it's NHS, I'm afraid it can't keep calling itself a learning organisation if it's the one that's doing it.
There's lots of dissertations been written about managing changes in the NHS over the years.
Yes, we'll save that for another meeting.
And they're all out of date.
Yeah.
They're written.
Dominic, yes.
So it's quite interesting, given that sort of stress and anxiety is our sort of top cause, I suppose. And then the most deteriorated score on the survey is a sense of people feeling there's enough staff in the organisation to do their jobs properly. And that is interesting, I think, because we probably haven't lost significant numbers of staff. They've just been aligned in slightly different ways and to place. And I'm just wondering if that gives us an opportunity to think about something that we could do to make people aware of who they can work with or should be working with through that transition. Because I think Jackie's right. This isn't all just going to sort of be perfect on the 1st of July. That transition is going to be an ongoing thing. And helping people identify, who else they are working with. It's not been helped by remote working either, I'm absolutely certain. But that looks like it would be the one that would make the most difference, potentially.
Shanaz?
So I don't know, but Sam at her last ICS session talked about the transitions model, where you have endings and then you go through a neutral zone and then you have new beginnings. And I'm having lots of conversations with people about this neutral zone because that's the uncertainty bit. And one of my personal worries about this neutral zone is how will I manage my workload going from virtual to face-to-face? And that, whereas before I would have been for the past 2 years, I've been able to do 5 or 6 different meetings. I can be in Leicester, then I can be in Birmingham, then I can be in practice. But actually, that is going to be really difficult for people to manage. But actually, the travelling, the seeing people face to face, which is lovely, but it's absolutely exhausting. And I'm just wondering what support. What we might need to think about is actually how we help people transition through that phase, because it will be tiring, it'll be costly for lots of people. Because if you haven't been travelling to work and you haven't been paying for petrol, but all of a sudden you've got to start paying for petrol, and that will have an impact on people who have or lower wages. So those are the type of conversations I'm having with people that I connect in with, is actually how do we help you through this neutral zone into a more positive new beginning.
But also, I guess, with all the things that we're learning from COVID, is what are the things that took place in COVID that we can learn from? And maybe virtual working absolutely has its place, doesn't it? It may well be that for some of those meetings they'll continue to be virtual, and then a smaller number maybe will be face to face. That value of meeting face to face for me personally today has been fantastic.
Absolutely, yeah.
Just to come and see people we haven't seen or met and had a bit of chat over a cup of coffee, those sorts of things haven't happened for a long time. And it may well be that we still have some of those. We keep quite a lot of stuff virtual, maybe a lot of our meetings, but we every now and then make sure we come together and our teams come together so they have a sense of identity and where they belong, but at the same time maximise the benefit of virtual working where we can. Okay, well, thanks, Joe, for being that paper. If we can move on then to the risk register report. We always end with exciting things.
Yeah, even more exciting for some of you, because we took a similar report to executive this morning, so apologies if we were hearing this twice in one day. We're only trying to stagger it over 2 different weeks, but the way it landed this week, and you got the joy of it twice. I want to share my screen, and you've got the cover report and the appendices, which has got a lot of detail in it as usual. It's first up to say, this is still a very active risk register and assurance framework. We're working with all the risk owners who have been diligently updating these as we go along, which is great because there's a requirement to hand over CCG's risk register as part of the due diligence process. So we're going to be maintaining this and keeping it very much up to date right until the last minute. And alongside that, what we're trying to do is with one eye on, I guess, future ways of working, even though we're not 100% clear of what those are going to be. We're anticipating needing to have some kind of risk register in both places. And so we're working through the risk register at the moment to identify those risks that apply to both places or just one of our geographies, or equally which of those risks are kind of statutory organisation risks that possibly should sit better with the ICB itself. So we'll be doing that in the background, but still maintaining the CCG risk register. So it's a lot of work going on in this area as well. So thanks to all colleagues who contribute to that, because it is a big task. And as David says, everyone's favourite task as well. I'll pick out a couple of changes. So we've got one new strategic risk around the election recovery programme, which Julia highlighted in the performance report as being an area of concern or an issue. 2 strategic risks have changed score. So one of the risks around primary care commissioning arrangements, and I think although the CCG's got an established process and arrangements in place, the transition to what comes next isn't clear yet. And I know Jeff's mentioned this on 1 or 2 occasions and reflected that uncertainty in the risk 1300 there. So it's now escalated to a high risk. We've reduced the risk around infection control, I guess, which have got good controls in place, which is great. So we've reflected that the risk is actually low risk now on the assurance framework. Other things to point out, we've got 1 extreme risks reduced to a high risk. So the IAP services in Newcastle, which Joe touched on earlier, and we know we've got the procurement successful procurement process, and we've got the new service has been appointed to Beta Health. So, and I think with the Wait English initiative that's going on there, we just really want to reflect that the risk, although there's still work to do. I think the risk appropriately reduced from extreme to high. The rest of the report just looked at some risks that have reduced in score and the reasons for that. A lot of that is around coming out, hopefully, with some of the COVID measures and some of the face-to-face issues we were having in the services aren't there anymore, so we've reduced some of the risks around that. I'll leave it there because there's obviously a lot of detail on the entities as well, but I'm happy to take any questions.
Okay, thanks very much. Yes, Michael.
Just to say that I was quite pleased to see quite a bit of movement among the various risks on there, which is very good because if we had the same risks with the same risk scores month after month, it wouldn't be risk management, would it? And I think it's good to see all this, that is actively being used as a tool to change things. I've been asked if I would advise internal audit who are going to talk to the ICB about does this risk register reflect our key risks here? I think yes, it does. Because it's always changing, it could be a different set of risks, in those times. So I'm quite pleased with that stuff.
Yes, Julia.
I was just going to say we've got quite a robust process, and certainly colleagues from NEXT, when we've been perhaps a little bit elusive, are very good at tracking me down to make sure we do those reviews. But that's a good thing. So they do a great job, and certainly things like deprivation of liberties and the new LPS standards are had as a more significant risk, and you can see that's changed because the guidance has been delayed. So absolutely, Michael, you're right.
Okay, thanks very much. Thank you for that, Julia. We're just noting, aren't we? And we're happy with it's a fair reflection of the risks that the CCG has at the moment. So thank you very much for that, Neil. We've just got other papers for information. So we've been able to enjoy those at our leisure. We haven't had public health colleagues joining us at all. So I believe, unless there's any other business, that that concludes today's governing body. I just wanted to say, you probably want to say something, Mark, in a second, so I'll let you say something first before you jump in. It's been a great honour to have chaired the CCG, and I think we've had some really troubling times, a huge amount of change, a huge amount of challenge around pandemic in particular, and now the recovery from the pandemic. And I just wanted to thank everyone for all your work over the years, whatever roles you've done. It's been fantastic, it's been invaluable. And I know there's uncertainty for many of you going forward, but I'm sure we will meet each other, I hope, in various capacities, even if it's just a social drink down the pub or a piece of cake out there or something like that. So, yeah, thanks very much for everything that everyone's done during the lifespan of the CCG.
Thanks very much, David. And I was looking back to our, I don't know if you've seen our circle model that we did with our values when we first set up the CCG, and how well, I think they've been really good values, and I think we've really served them well. And I think that care, that compassion, that real duty to our public that we serve, I think we've done a really good job of that. I think we've connected well with our front line. I think we've been able to support our workforce in a variety of sectors, and I know often we're accused of just supporting primary care, but I do think we have looked very well at the other sectors, at least the voluntary sector, trying to make sure we've done a lot of work with, increasingly with our social care, and certainly a lot of work with our acute sector. So I think we've got so much we can be proud of. I think we've got lots of great relationships and things in place that we leave as a legacy that hopefully we can build on, and other systems. And as we know, this reorganisation, there are many things that will just take existing functions, existing people and relationships and build on them. So I think whilst we see a lot of change, there is absolutely a lot of foundations that won't change, that will continue, which is great. So yeah, a huge thank you to everyone's contribution, everyone's wisdom, everyone's patience at difficult times. But as I say, I think the support amongst us all getting through these difficult problems has been particularly valuable, and I've certainly valued it personally when it all helps me out of sticky spots. So thank you very much.
Sorry, could I respond?
You can respond.
Just because I'm probably one of the newest members of the CCG, but I'm just reflecting that our primary accountability is to the public of Gateshead and Newcastle. And I think endings are very important, and I think it's important for all of us to have a think about the work that we've been involved in, whether it's been being robust around constructively challenging the quality of the services that have been delivered. And I think we have done that very constructively. We've done it in a way that I think has preserved and grown relationships with our providers. And I think we have very strong relationships with those providers where we can have frank and open conversations and challenge quality. I think we've got very robust processes. But I think we can also be very proud at the services, even in my short time, but in your longer time, that we've procured and that we've done with very much the values and the needs of our patient population in mind. And I think I just ask each of us to think about which of those services are now in place that weren't in place when we started on this journey. And I think we should all be very proud of what we've achieved, and particularly thinking about the population that we serve. We've delivered some excellent services.
Fantastic. Yeah. And hopefully we're in a much better position with our relationships between providers as well. It does feel as though we've got a lot of work into relationships between different sectors. And if I think of our system work we have in both places, it's you think back to times when you didn't think that was possible. So I think we've got some fantastic assets there. I do think, though, just going back to some of the other things we've got to remember is we've ended up hosting a lot of stuff in the region. We've influenced the region, but we've also influenced the country on some of the things. Think back to our innovative way of putting one-on-one slots, and that's national now. There are many examples that we've started things here that are national, but there's a lot that are regional as well. So, yeah, thank you.
We've got to meet again on the 28th, so we'd say it all again.
So we can say it all again, and we can showcase all the good things. Jeff, your hands up.
Yeah, thank you. Interesting just to sit back and listen to the conversation. Particularly, the word change has been used a lot, and let's not forget that change has been constant at our CCG since year 2, when we merged and we became an alliance and we did all these other things. So the fact that the officer team has managed another significant change is of no surprise to me, because you've been managing change since day 1 and managing it very well and making those transitions. But I also think it's also good to reflect on the change of personnel that you've had to deal with. Some of those in tragic circumstances, and some of those in not so tragic circumstances. And despite the change in personnel, the officer team have maintained an incredibly high standard. They're outstanding Ofsted rating most of the time, and all the other things and awards and accolades that are sitting on the desk outside your boardroom door there. And that's that's testament to a well-led organisation that is able to weather change and all that sort of stuff. So it's not just about the change to the next organisational structure, but I think it's about all those people that enabled us as lay members to ask those ridiculous questions like, what do you mean a never event's happened? It should never happen. And not look at us with disdain and with as if we've just walked off of a different planet when we ask those questions, and enable us to challenge you robustly and maintain positive professional working relationships. So I'd just like to thank everybody for that, and I'd also like to say to Jackie Cairns, good luck in her retirement, and you'll be sorely missed. Just I can see you there, Jackie, on the screen.
On that note, I call this meeting to a close. Thanks, everyone. Thank you.
Thank you.
And hopefully we'll see you all on the 28th. Yes.
Please take food, cake, with